You can start whenever.
Okay. Hi, my name is Andrew Willeford, and I am a current PGY2 in cardiology here at the School of Pharmacy at University of Maryland. I'm very excited to talk about something in regards to a new realm of possibility in heart failure with reduced ejection fraction, that being sodium glucose cotransporter 2 inhibitors in heart failure with reduced ejection fraction. So by the end of this presentation, my expectations for you is that you'll be able to explain potential mechanisms of sodium glucose cotransporter 2 inhibitors or SGLT2 inhibitor efficacy in heart failure with reduced ejection fraction. You'll also be able to compare differences between EMPEROR reduced and DAPA-HF, as well as at the end, given a patient case, select an SGLT2 inhibitor based on current evidence. So let's give you a little sneak peek at that case. So we have a 67-year-old white male with a past medical history of ischemic cardiomyopathy, NYHA class 2 heart failure with reduced ejection fraction, MI, CKD, hypertension, and hyperlipidemia, who's ready for discharge after being admitted for symptoms of heart failure. He initially presented with volume overload without signs or symptoms of cardiogenic shock. He was given IV diuretics and is now euvolemic. Now, you, the pharmacist, want to make sure he's on the best optimal guideline-directed medical therapy before discharge. So let me give you a little spot at his meds. Inpatient-wise, he's on very similar to what he was on prior to admission, that being his home medications. He's on Spiro 25 milligrams, Atorva 80, aspirin 81 milligrams, torsemide 40 milligrams, carvedilol 25 BID, as well as isosorbide and hydralazine. So let me just ask you that question real quick is what do you think is missing from his medication list? Just something to think about in terms of what do you think and what would you need to consider to add to his GDMT. So we'll think about that as we go through the rest of this presentation. So before I get heavy into it, I think it's a very fascinating story to discuss about how do we get to where we are with respect to SGLT2 inhibitors. What's really interesting to know about them is that their benefits in heart failure with reduced ejection fraction are really rooted in serendipity. It all started in 2007 when rosiglitazone was found to be significantly associated with a risk of myocardial infarction in a meta-analysis. The next year, the FDA, in response to this meta-analysis, actually made a mandate for all forthcoming diabetes therapies to have cardiovascular outcome trials. They also placed a REMS requirement on rosiglitazone. I just want to note that that risk for MI has since been refuted and that REMS program lifted from rosiglitazone. But regardless of all of this new development, the FDA kept that same cardiovascular outcome trial requirement. So in 2013 to 2017, the incretin-based therapies started to come to the market, that being like the DPP-4 inhibitors like alogliptin, linagliptin, etc., as well as the GLP-1 receptor agonists like liraglutide and dulaglutide. Now, overall, the GLP-1 receptor agonists mostly showed reduced major adverse cardiovascular events. Similarly, in around the same time, SGLT2 inhibitors began to be studied, that being a Canvas, EMPA-REG, Declare-TIMI, and the newest VERTIS-CV trial. They all revealed varying but overall beneficial cardiovascular outcomes in patients with diabetes. So if we look specifically at those initial diabetes trials with SGLT2 inhibitors, the first being EMPA-REG outcome, which looked at empagliflozin versus placebo, they found that with regards to cardiovascular death, there was a significant reduction in patients taking empagliflozin. Same with heart failure hospitalization. When you look at the other studies that have come out, that being Canvas, Declare, and the newest VERTIS-CV, they show a little bit something different where there was no significant reduction in cardiovascular death, but a definite significant reduction in heart failure hospitalization in patients on their respective SGLT2 inhibitor. So my question here is which of these trials or trials had a non-significant finding for a composite of cardiovascular death or heart failure hospitalization? What I show you here are the individual components. What about the composite? Which one was non-significant? So the one that was actually non-significant was only VERTIS-CV. That composite cardiovascular death or heart failure hospitalization was not significant. Reasoning for these differences among the trials is a little bit unclear, but a lot of it is thought to be secondary to differences in baseline characteristics in these populations. So all of these findings with regards to beneficial effects in patients and with respect to cardiovascular death and heart failure hospitalization led to a multitude of mechanisms or hypotheses for mechanisms which really remain to be further elucidated. So the mechanisms we think that take place are all involve metabolism, inflammation, diuresis, and hemodynamics. And it's not that the combination of all of these mechanisms is the likely result of why we see these beneficial effects. With regards to metabolism, perturbation of myocardial bioenergetics is thought to contribute to heart failure. With regards to SGLT2 inhibition, the thought is that SGLT2's inhibitors can actually promote the production of ketones, which become very efficient or good energy sources for cardiomyocytes to utilize, in particular in patients with heart failure. With regards to inflammation, what's very well known is that inflammation plays a major role in cardiovascular disease. The thought is that SGLT2 inhibitors actually help with inflammation because it's been demonstrated, at least experimentally, that they can actually reduce or decrease inflammatory markers in the blood. Now, the most well-studied mechanism is through diuresis and hemodynamics. In the world of diuresis and hemodynamics, I think it's best to take a little closer look at the proximal convolute tubule and the site of action of SGLT2 inhibitors. So if we look on the left of this little diagram, we have the lumen, on the right is the blood. The SGLT2 cotransporter transports glucose and sodium into the cell, which is then transported out of the cell and into the blood through the GLUT2 transporter for glucose and the sodium potassium ATPase for sodium. Now what's known is that SGLT2, the transporter, interacts with something called the sodium hydrogen exchanger, or what I call NHE3. And what's known is that inhibition of SGLT2 actually effectively interferes with NHE3 activity, and this is thought to result in the production of further natriuresis, and this has actually been demonstrated clinically as well. Now, while we think that this mechanism or salutary mechanism of SGLT2 inhibitors are likely multimodal, like I said earlier, really remains to be fully elucidated with regards to how it really amounts to the beneficial effects in patients. But regardless, we definitely still know that there are beneficial effects in patients with heart failure, and that's very well demonstrated in the initial trial of DAPA, or dapagliflozin and DAPA-HF, which was published in 2019. Now, in this study, they really just asked a simple question: what effect does dapagliflozin have on a population consisting entirely of patients with heart failure with reduced ejection fraction? They recruited about 4,700 patients, followed them for a median of about 18 months. Mostly were white, 70%. 67% had heart failure NYHA class 2 symptoms. About half, or a little bit less than half, had diabetes type 2, as well as about 50%, 47% to be exact, had a history of heart failure hospitalization. 34% had some sort of device therapy, that being the ICD or cardiac resynchronization therapy, that CRT. With regards to background GDMT or guideline-directed medical therapy, they were very well treated in terms of beta blocker use. 96%, 71% were on an mineralocorticoid receptor antagonists like spironolactone or eplerenone. Almost everybody was on a RAS inhibitor, that being about 84% ACE inhibitor or ARB, as well as 11% being on sacubitril valsartan, or that ARNI. Now, in this patient population, when they looked at their primary composite outcome, that being a composite of cardiovascular death, heart failure hospitalization, or urgent visit requiring IV therapy, when they compared dapagliflozin 10 milligrams to placebo, they saw a significant reduction on the order of about 5% in patients taking dapagliflozin 10 milligrams. Now, importantly, in their pre-specified analysis, patients who had diabetes type 2 versus those who did not, they still found significance regardless of the absence or presence of diabetes. Now, this was very groundbreaking because we hadn't seen anything since sacubitril valsartan that could provide such benefit. And so this was quite exciting, that spurred a lot of investigation for further trials, which we'll talk about in a moment. But with regards to adverse effects in this trial, they saw no difference in volume depletion, amputation, hypoglycemia, or diabetic ketoacidosis. Now, multiple post hoc studies came out after DAPA-HF was studied or published. One of the first being that demonstrating that benefits were independent of the presence or absence of diabetes, which we kind of knew from that pre-specified analysis. But importantly, they also showed that benefits were independent of baseline A1C, meaning if I was diabetic and I had an A1C of 8, I would see benefit from dapagliflozin. If I was diabetic and I had an A1C of 7, I would also still see benefit of dapagliflozin. Also importantly, in another study, the post hoc study of DAPA-HF, they demonstrated that benefits were independent of background GDMT. Also even showed that it was independent of background ARNI use. You need to take it with a grain of salt, given they're only 11% on sacubitril/valsartan, but regardless, they still showed this. One important thing I want to take away from this post hoc analysis is that dapagliflozin was found to be associated with volume depletion in patients taking diuretics. This is nicely backed up in another post hoc analysis, which at least showed that diuretic dose did not change in most patients during follow-up in DAPA-HF. However, dapagliflozin was associated with volume depletion when patients were taking diuretics at doses greater than or equal to 40 milligrams of furosemide. So altogether, all of these post hoc analyses show that benefits of dapagliflozin will be there regardless of the presence or absence of diabetes, regardless of background GDMT, and that there is maybe an association with volume depletion in patients on higher doses of loop diuretics. So here's what we know. We know that SGLT2 inhibitors have positive cardiovascular outcomes in patients with diabetes, and that their mechanisms of action on how they provide those benefits really remains to be fully elucidated. But regardless of those enigmatic questions that remain to be answered, DAPA-HF revealed cardiovascular benefit of dapagliflozin in patients with heart failure and reduced ejection fraction and without diabetes. This earned them the indication from the FDA for use of dapagliflozin in patients with HFrEF and without diabetes. So the newest bit of data that we have that has come out in the past 2 months really likely indicates a class effect of SGLT2 inhibitors in heart failure. That new data is ever reduced. And similar to DAPA-HF, the investigators in this trial asked, what effect does empagliflozin have on a population consisting entirely of patients with heart failure and reduced ejection fraction? With regards to their baseline characteristics of the population, they recruited about 3,700 patients, followed them for a median 16 months, 70% were white. Patients, about 50% had diabetes type 2, 43% had a device, that ICD or CRT. About 75% had NYHA class 2 heart failure symptoms. At baseline, NT-proBNP was about 1,900, ejection fraction 27%. And with regards to that guideline-directed medical therapy at baseline, again, very good medical therapy, 95% on beta blocker, 71% on an MRA. Almost everybody was on a RAS inhibitor, with in fact 19% on sacubitril/valsartan. Now, with regards to the primary composite of cardiovascular death or heart failure hospitalization, the investigators found that empagliflozin 10 milligrams significantly reduced that composite. If you're like me and you like to look at the numbers, well, by the end of the trial, they show that there was an absolute risk reduction of about 5% in patients taking empagliflozin 10 milligrams as compared to placebo. So similar to DAPA-HF, a number needed to treat of about 20. Now, with respect to adverse effects, there were no differences except in genital infections. So patients taking empagliflozin had a higher risk for genital infections. This is not surprising given we already knew this from the initial diabetes trials, but they saw no difference in volume depletion, amputation, hypoglycemia, or diabetic ketoacidosis. When you look at the pre-specified subgroup analyses, once again, very similar to DAPA-HF, you saw benefit regardless of the presence or absence of diabetes. You also saw benefit in class 2 NYHA. Statistically, you saw no difference in class 3 or 4. However, I do want to point out this study is not powered to look at patients with specifically class 3 or 4 symptoms. So I think it's important to note that I think that if this study was powered to look specifically at that population, you would very likely see a benefit. Now, with regards to background GDMT, didn't matter, you still saw benefit regardless of the presence or absence of those medications. So I think it's nice to compare Emperor Reduced versus DAPA-HF, in particular their baseline characteristics, because it can kind of clue us in to the reasoning behind why we might see differences in their outcomes. When you look at past medical history, about 43% had some sort of device therapy in Emperor Reduced versus 34% in DAPA-HF. I think that's a very important consideration to keep in mind, given these devices are there to prevent death from happening in patients on the verge. And this can definitely have an effect on cardiovascular death outcomes in these trials. Furthermore, there is a difference in baseline NT-proBNP 1900 versus 1430, also as well as ejection fraction 27% versus 31%. Also importantly, there's a difference in baseline use of sacubitril valsartan, a bit more in Emperor Reduced as compared to DAPA-HF. Now, these differences in baseline characteristics may explain why we see no significant difference in cardiovascular death in Emperor Reduced, while seeing a significant difference in cardiovascular death in DAPA-HF. We do see a difference in both trials with regards to heart failure hospitalization. So if we put everything together, Emperor Reduced, DAPA-HF, and those initial diabetes trials, what we know is that, like I showed you already, no difference in cardiovascular death in Emperor Reduced versus a difference significant in DAPA-HF. But when you look at EMPA-REG versus DECLARE-TIMI, the outcome is almost flipped. You see a significant difference in cardiovascular death in EMPA-REG versus no significant difference in DECLARE-TIMI. Across the board amongst all 4 trials, you do see significant difference in heart failure hospitalization. But this difference in cardiovascular death, like I kind of alluded to earlier, may likely be explained by differences in baseline characteristics. So looking at this information, I find it would be very hard to specifically say I choose this medication over the other based off of the results. I think there is likely a class effect amongst these two, given the fact that there are differences in baseline characteristics and the fact that we do see benefit in cardiovascular death in both categories. So there are important considerations to take into mind before starting an SGLT2 inhibitor. Some nice numbers to think about is that there is a good renal cutoff of about an EGFR of less than 20. Don't use it if you're less than that. This really comes from the Emperor Reduced trial, which had a renal cutoff of 20 EGFR. DAPA-HF used 30, but given the fact that Emperor Reduced used 20, I think it would be safe to utilize SGLT2 inhibitors down to 20. Also, the dose for empagliflozin and dapagliflozin is 10 milligrams, no titration. You set it and let it go. The A1C reduction is really modest at best with SGLT2 inhibitors. It's only about 0.5%. And there is a mild reduction in systolic blood pressure in patients taking SGLT2 inhibitors on the order of 2 to 5 millimeters of mercury. 5 millimeters of mercury is more common to be seen, that higher end, at least earlier on in use, which is kind of demonstrated in the supplement of Emperor Reduced. But over time, that blood pressure reduction tends to normalize closer to baseline at about 2 millimeters of mercury reduction. Now, with respect to monitoring and educating our patients, it's very important to know that patients are at risk for volume depletion with higher doses of diuretics, but I don't think it's a great idea to empirically adjust doses just because we're starting an SGLT2 inhibitor. I think it would be more important to know that we're placing an SGLT2 inhibitor on them and that we need to closely monitor and educate the patient to look for signs and symptoms of volume depletion and then adjust doses of diuretics accordingly. With regards to genitourinary infections, definitely an increased risk in patients taking an SGLT2 inhibitor. And this is extremely important to educate our patients on the importance of good hygiene, given this can be a very limiting adverse effect that could prevent our patients from taking this potentially life-saving medication. Also, an important consideration for us to know is that you may actually see an initial fairly decent decline in EGFR of about 4, followed by an overall reduction in risk for worsening renal function, meaning that over time there's actually a renal protective effect of SGLT2 inhibitors, which is actually being studied in clinical trials right now, including DAPA-CKD and another one for empagliflozin. A rare but very serious side effect to look out for is euglycemic acidosis, when a patient presents an acidosis but with normal to moderately or mildly elevated blood glucose. Patients who are at highest risk for this rare complication include those who are acutely ill, dehydrated, or have just had an excessive intake of alcohol. This is very important to keep in mind with regards to those with diabetes who may be sick, given you would want to educate them and advise them to hold their SGLT2 inhibitor on those sick days, given they are at a higher risk for euglycemic acidosis. The same idea goes into those with type 1 diabetes, given there is thought that patients with type 1 diabetes are at a higher risk for euglycemic acidosis. And I think this is reflected in the fact that all of these SGLT2 inhibitor trials excluded patients with type 1 diabetes. So with all of this in mind, we know that SGLT2 inhibitors provide mortality benefit in patients with heart failure and reduced ejection fraction. So I think it's time that we build a new backbone for guideline-directed medical therapy, that being ARNI, beta blocker, MRA, and SGLT2 inhibitor. If you were to ask me where to place SGLT2 inhibitors in the algorithm of guideline-directed medical therapy, I think it should go last. It's not because I don't believe in SGLT2 inhibitors being beneficial products and medications for heart failure with reduced ejection fraction. It's just that comparatively to other trials with sacubitril valsartan, beta blockers, MRAs, the mortality benefit just appears not to be as great as those in the other trials. However, definitely we should still use this medication, but I would place it on last. Now, the studies are not done despite all of the data that we just looked over. There's a whole lot more to look forward to in the coming years that we'll be able to look at and learn more about empagliflozin, dapagliflozin, and other SGLT2 inhibitors. Now, despite these upcoming clinical trials, there are other questions that remain. That being, should SGLT2 inhibitors be held during acute decompensated heart failure, in particular those with volume overload but not cardiogenic shock? Do we hold the SGLT2 inhibitor when they come into the hospital, or do we continue it? Also, it'd be great to understand what are the effects in patients with a heart transplant or an LVAD, that left ventricular assist device, as well as understanding the effectiveness of SGLT2 inhibitors in underrepresented populations, given the trials that we talked about only or mostly had patients who were white. So let's end it with the case. We're back to our patient looking to get best possible GDMT before discharge. These were his medications. So my question is, what do you need to know? What kind of lab parameters, vital signs would you want to know before considering improving this patient's GDMT? Well, what we know is that his blood pressure is 113/68. We know his EGFR is 28, his renal function is stable. His echo is 31%. He has an allergy to candesartan, and his allergy is angioedema. It's always important to ask, what is the allergy actually true? Well, yes, there's actually real documentation for real it's angioedema. So with this in mind, it kind of seems like we can't place this in a RAS inhibitor on this patient. So we definitely should just take the step into an SGLT2 inhibitor. So my question is, which one would you recommend, dapagliflozin or empagliflozin? If it were me, I would choose the one that the patient's insurance covers, with either or, given I think there is a class effect of these SGLT2 inhibitors in heart failure with reduced ejection fraction. So I want to say thank you to my RPD and awesome mentor for this presentation, Dr. Stormy Gale. She's been awesome with respect to helping me design these slides, think critically, and analyze everything that has been presented just recently, as well as I want to say thank you for taking the time to listen.